So we come to a session on robotics, which will be the overview of robotics in our country, which is available. So I will, first of all, I'll call Dr. Narendra Vaidya from Pune, which has kindly consented to come all the way. And he will demonstrate, talk about robotics. And he already will be taking a workshop where the delegates who have registered for robotics will get a hands-on on the robotic arm by debut. But here we'll be talking about all the robotic arms available in India. So Dr. Narendra Vaidya will lead the way and he will be assisted by so many people who do robotics, different varieties. Dr. Amit Jaiswal from Varanasi, Dr. Anil Arora, my best friend from Delhi, Dr. Nabil Gareb from Israel, he also uses a robotic arm. Dr. Sarup Patel, I don't think whether he has come or not, but from Varanasi, he is there. Dr. Rajkumar Natesan, he is again a big man, you all know the amount of volume of work he has. Dr. Simon Thomas, which I admire, he is very straightforward. I met him once only and then this time I was bent upon that he should be here, and thankfully he is here. Dr. Sanjay Srivastava, who is just trying to grab the feel of robotics and will start the robotics, apart from the couple of players we have in Varanasi and 3 players, I think 1 player in Ghaziabad. So our UP is going to have robotic arms. Dr. Sanjay Srivastava is there. And Dr. Rakesh Rajput, again a very good old friend from Calcutta. So they all will give you some idea of what robotic arm they use and how they are going to utilize it. Thank you.
Thank you, Dr. Prasad, for inviting me for this August gathering. And I'm really very happy to come here and address this audience. So I've been using different robotic systems since 2016, and more than 10,000 odd cases we have done on the various robotic systems. So I'm going to take an overview of all the systems and try to put pros and cons of everything. So what is the robot? It's a machine which is programmable and is capable of carrying out complex series of tasks automatically. Now in orthopedics, the applications are increasing. Earlier it was, when it was launched by Stryker, it was only Makoplasty, that was only partial knee. Smith & Nephew also, when they launched Navio, it was only for partial replacement. But the applications have now increased, and now even last month I was in US, where now the applications for revision also are being launched early next year. So the overall spectrum of use of robotics is going to be huge. Means all the arthroplasties, including revisions and even sports medicine, shoulder also, robotics is going to come in picture very soon. There are downsides also, definitely. There is the cost element, there is a learning curve. When I started doing robotics, the routine case you used to finish in 25-30 minutes implantation. And the first case I did, it took almost 2 hours, and then that was the thing. And then now, if you see first 70-80 cases, we got a data. Now it's almost same like what conventional TKR takes. So there is a learning curve, and initially the new users may get frustrated with this increased time, because it's a different type of surgery. It's not exactly the way we used to do the manual or conventional TKR. And we have to see for the long-term results whether there is a significant difference, because now the alignment philosophies are changing. From mechanical, we are going to kinematic, restricted kinematic, functional alignment, personal alignment. And early results are encouraging, but we need to see for 15 and 20 years of survivorships. But overall, I think the market for robotics is increasing, the usage is increasing day by day, and it is phenomenal since last 2-3 years. And I am very happy to know that India is moving even at a faster rate as compared to US as far as the adopting of the technology is concerned. Most of the major implant manufacturers have their own systems. Stryker has Mako, Smith & Nephew has got Cori or Navio, and then Rosa is there, Velis has been launched. So I have used almost all systems in our hospital at Lokmanya Hospital. Even you see the patient interest also is increasing. Patients' demand for technology, and they are, especially adoption of technology is very fast in our country. You see the example of mobile phones. Nobody imagined that these many mobile phones will be used, but now everybody, even an illiterate person, takes help for the GPS to go to a destined place. So robots execute the task better and more reproducibly and more, objectively than humans. They have the task more precision is there, more accuracy is there. So there is a potential advantage. One has to remember that robot doesn't have a brain. You have to use your own brain. Robot will do what you command and what you ask the robot to do. So if you leave everything to the robot, then there will be a problem. So you have to always keep in mind all the basic principles of your TKR. Robot will not make you a better surgeon. Robot will make your plan execute in a better way. That is the main thing one has to remember. Otherwise, new surgeons may get a thought that I get a robot and I get, some marketing value, then I get, better surgery. It will not make the surgery better. It will execute your plan in a better way. That's the main message. So there are broadly in our country, we have robots which are image based, that is either CT scan or X-ray based. CT scan is done for hip, knee and entire axis is calculated. The bone shape and bone sizes are taken, that is with the osteophytes. The imageless systems like the Cori, then the Velis, these are imageless systems where you have to map the native bone and then almost same way they will function. So there is one more important thing which is called as haptic control robots. Now what is haptics? Haptic is a feedback given by the imaging either intraoperatively or preoperatively taken, and then the robot knows where to stop. So it works within the boundaries, making the surgery safe. So there are some haptic control robots which are basically CT scan robots, like the Mako is there or Velis is there. They work within the boundaries of CT scan marked images. There are semi-haptic like the Cori, where whatever you have marked, actually mapped during surgery, that will work only in that particular region. If you go out of that region, then the robot will stop operating, which adds to an element of safety as far as protection of ligaments or protection of neurovascular structures are concerned. So these are some images of CT-based robots in hip or knee, where all the measurements are taken on the CT scan, and then the robot will work, either burr or saw, it will work within the boundaries. This is an example of imageless robot, Cori or Navio, where you move the probe which is on the bone, and you have to take care that it doesn't get lifted off from the bone. And then once it is done, it will give you the size, it will give you the native, whatever anatomy of the femur, tibia is there. You can adjust your rotation also again if required. And similarly, tibia also you can do this. One more thing is there that you can add some special points also here, so that if there is some bone loss, say for example in valgus knee, there is a distal and posterior condylar, lateral condylar bone defect, then you can readjust the rotation, taking the epicondylar axis also. So there is a lot of modularity during surgery. Other classification of robot is automatic or semi-automatic. Most of the, if you see the global level, then most of the robots are semi-automatic. They are controlled by the surgeon all the time. In India, there are some robots which are launched, which are fully automatic. Means the surgeon takes the incision and then approach, and then the robot takes over. So surgeon is not involved in the surgeries. Personally, I'm a bit skeptical about this type of systems, because you have to first of all fix the leg to the table with two broad pins, and then the robot takes over, and then you are just out of the equation. Sometimes things can go south. Semi-automatic, the surgeon is always in control. It is at the even if the system fails in between, then surgeon can take over from there. So they are haptic, semi-haptic or planar haptic. There are various systems which are classified in semi-automatic also. So here the surgeon is always in control, and constant input is given by the surgeon. So it can be again image based or imageless systems. So robot will tell most of the information which is there. These are various screens in various systems which I have used. The Cori, you get these images where you get a sticky image where you see the implant on the bone. You can move the images and see how the implant is fitting. You can rotate with the touch screen. Then you have some screens in ROSA where you see these various gaps, and then you can adjust the components in all three dimensions. That is a great advantage of robotic systems, where you can adjust the femur flexion, extension, varus, valgus, or you can take it distally or proximally, and so you can adjust the gaps. So you are, by adjusting your bony cuts, you preserve your soft tissues. That is a very, very important, sort of advantage given by robot. So it gives the hip center. There is no, ambiguity about it. So every case manually, whenever we don't calculate. Most of them don't calculate the angle between the mechanical and anatomical axis of the femur. So we take 6 degrees as a constant. We take 3 degrees as a rotation. But everybody's knee is different. Now, if you read some articles, latest published articles, there are 9 phenotypes which have been described for the leg, and you have to get to whatever phenotype of the patient, he had type 1, type 2, and you try to, match that. And that will probably reduce the unhappy 19-20% patients which are there in our literature. So we take a stress range of moment, which gives the idea about the tightness of the ligaments. Now, some companies are launching digital sensors also, where objectively you can assess what is the contracture or what is the tightness in the ligament. So all this, terms like adequate soft tissue release, optimum soft tissue release. What is optimum for me may not be optimum for Rakesh or other surgeons. So it is very subjective right now. So we'll get a very objective idea. There are graphs and plots which show you the dynamics of the joint, and then 3D models are there. So this is now a planning screen of Navio, where you can move this. You get this line diagrams, or you get sticky diagrams. You see this stress range of movement, where you can see the orange lines are medial compartment, and when you stress it, it is getting corrected. So there is no need in this case for any soft tissue release. So unnecessarily you don't need that. And then you get these bars where you can balance the knee absolutely sub-millimeter level. So that is how you can get an objective idea. You can release, again go back, release, again go back in a contracted knee. And so there is no excessive sort of release which is there. So in short, robot allows us to have a perfectly sized, perfectly kinematic, stable joint, and that is throughout the range of movement. In a conventional TKR, we used to balance the knee in 90-degree flexion and extension. But here you get entire range of movement, where we can see that the knee is absolutely balanced, which can take care of things like mid-flexion instability and things which have not been really answered with the conventional surgery. Execution of the plan is a relatively simple thing. Actually, on the robotics, we do the surgery virtually on the computer first, and then the robot implements it, either automatic or semi-automatic. So there are various modalities. Either you take it out with a robotic control saw, or with a burr, or you have some systems where the jig placement is there, like in Rosa of Zimmer. Then you have planar haptics, like in Wellis. So there are various modalities, which is a relatively simple sort of a thing. So there are, in Cori, there are 2 modes where exposure control, speed control is there. Mako works on with saw. In Uni, you can work with the burr also. Cori has got, again, exposure control mode, where the burr will retract inside the sleeve, or speed control, where it will stop rotating if you are out of the zone of cutting. And Wellis and Rosa, you still have to depend on the personal feel, because there is no stop or there is no haptics as such in these 2 systems. So there is a burring of bone, where you get a virtual image. You have to look at the screen and then do it. So it's like arthroscopy. You don't look at the knee and do this burring. And now with Cori, this burr has become really efficient, where it hardly takes any time to remove it, and gives a fantastic, nice surface. This is a video of Mako, where you get these images, you again reconfirm it. So you take almost double time. Some time you have to spend in planning on the CT scan, and then you have to again register it during surgery also, all these points, and so to reconfirm it. So it takes more time. All CT-based systems have tremendous, quite significant radiation exposure. Some papers are there where you see that they have documented it's 1 CT scan for 1 CT-based imaging is equal to 183 X-ray chest. So it's quite massive. So, and there is no significant difference which is seen on a CT-based or a real-time mapped robotics as far as the accuracy is concerned. So you have to take your own call. I don't use a CT-based system as far as my own choice is concerned. Now this is Rosa, where it places the jig and gives you the exact plane. Again, you have to use a conventional saw. So the drawbacks of all the whatever saw is there, normal routine manual saw, they remain in this system. Even if your cuts are directed well by this jig, skiving of the saw or, dipping in the osteoporotic bone, still it is there. The Velis system, it is now is a planar haptic, means the saw will be cutting in the plane. It doesn't have a stop, but you have to depend on your own judgment, like in a conventional saw, and it takes its own plane and then cuts it. The accuracy of this system is quite good. The saw blade thickness is 2 millimeters. I think I am hearing myself now. Acha, that video is there. Okay. Okay, so you can check your cuts. You can see that it's very accurate because the saw is thick and it doesn't skive off the bone, and you get absolutely dynamic sort of a stability in this. So this is a comparison. I think most of the things we have already covered. What the literature says is encouraging. At least the midterm and short-term results are very good in favor of robotics. So if you see the accuracy, it has been now absolutely documented in cadaveric studies. If you see the outliners in robotic, it is hardly anything, whereas in conventional, it was more than 20%, and that is a problem. If you see, then the recovery is also fast. In this paper, they have documented that there is decreased pain, improved early functional recovery, reduced time to hospital. It is also seen that the precision is more. There is reduced periarticular and soft tissue injury. There is this MUSTI score, which they have documented. Now, I am using this for soft tissue releases, how much you have to release. And we are trying to document the release of ligament is less in this. Some of our own papers where we have used robotics and shown that in risky cases, the risks are less. This was one paper we published. It was, we found that in conventional, there was significant cases where there was elevation of the joint line, whereas in robotic TKR, we have absolutely restoration of joint line was perfect. Learning curve is also, about 20 odd cases, 25 cases. This was one more paper where I told about this paper where joint line restoration was there. Another paper where we have now, this is the first paper with 600 unicondylar with 5 years of follow-up. It's the largest paper till date for this thing where unicondylar replacement is showing excellent results. So robotics is here to stay and grow. So I think that one thing message has gone very clear and loud. Because it is more accurate than manual, it reduces outliers from 28% average to less than 1%. Short-term and mid-term studies have shown better outcomes. Every system has having advantages and limitations. So you have to adapt to certain systems, because to adapt to burr-based system takes some time. It is sometimes very hard on your hand also if you have to do a couple of cases back to back. So we are now, trying to have various alignment philosophies also, which manually was only one philosophy, that is mechanical alignment. Now we are exploring various other things, and early results are really, really, satisfying. So we need to just look at the technology in a positive way, try to learn about it, and that is the future. Thank you very much. Yeah. So I invite other panelists, Dr. Vinay. Not there, okay. Dr. Amit Jaiswal. Dr. Anil Arora. Dr. Hemant Sharma. Dr. Nabil. Dr. Swaroop Patel. Dr. Raj Kumar. Dr. Simon Thomas. Dr. Sanjay Srivastava. And Dr. Rakesh Rajput.
First of all, I would like to thank Dr. Prasad sir and the Cawnpore Arthroplasty team for inviting me to present my lecture on robotic knee arthroplasty in complex primary varus. I think a lot of things have been covered by Vaidya sir, so he made my job easy. arthroplasty in complex primary knee. To start with, it's a case of 77-year-old female having pain in her both knees, severe varus, and fixed flexion deformity in his left knee. So with the help of two assistant braces on her both knee, and with the help of walkers, he is merely able to walk properly. So this is her gait. So now it's a case of complex primary severe varus, 35-degree anatomical varus, and if we talk about the mechanical varus, it would be around 41 to 42 with fixed flexion deformity of 10 degree. So the challenges in these cases is restoration of mechanical axis, as there is a complex primary varus. Another challenge is soft tissue balancing, and third is the use of minimum constraint implant. So what should be the choice of implant in such cases? Should we go with the conventional TKR, or should we go with the semi-constraint, as there is a ligamentous laxity on the lateral side and a soft tissue contracture on the medial side? Challenges were in tibial cut, femoral cut, and medial release. I'll discuss one by one. So what extra precautions should we take while dealing with these cases in tibial cut? It is always advisable to cut the tibia less. We should not cut the tibia with the 9 mm, but how much less? Should we go with the -2 or -4? And if we are planning for -2 or -4, why not -3 or -1? So it is the surgeon's decision on table whether he should go for a -2 or -4, then check the balance, check the gap and then balance, and then revise the cuts. And it's always advisable to do the medial release extensively. We should remove the osteophyte, and sometimes you may require to downsize the tibia and lateralize the tibia. And even if all these releases and downsizing, sometimes you may require the epicondylar osteotomy as well. In femoral cut, again, we should cut the femur less, as there is a lateral laxity. But how much less, -2 or -4, again, it's a controversy. And valgus angle of the distal femoral cut should be less, because if we'll cut the femur in more valgus, then again there will be more opening on the lateral side and less opening on the medial side. So I did this case with the Velis robotic assisted device, which has 3 component: robotic arm, satellite station, and base station. It is a real-time navigation robot with a robotic arm. It is a table mounted system. So this was my initial leg alignment after the meniscal release and minimal medial release. I could able to correct and I could achieve the 26-degree varus with lateral opening of 10.5 and medial 3 and -2.5. After the extensive medial release and removal of all the osteophytes, I could able to achieve 6 mm posteromedial and 0 mm anteromedial. And again, the lateral remains the same 10.5 and 11. So again, there is a mismatch in the medial and lateral opening. So I took the help of intraoperative planning, where I cut the femur in 2-degree varus. I had opted for tibial cut again in the 2-degree varus. I had actually rotated the femur and flexed the femoral component to 5 degree. So 2-degree varus in femur and 2-degree varus in tibia, 5-degree external rotation in the femur and 5-degree flexion. These femoral positioning we cannot achieve on the conventional method. So in intraoperative planning, we cut the tibia in 2-degree mechanical varus, downside and lateralize the tibia, cut the femur in 2-degree mechanical varus, and femur in 5-degree external rotation and 5-degree flexion. So this was the final leg alignment. After all the cuts, I could able to balance everything properly. This was the post-operative X-ray. I managed this case with 6 mm insert only. As there is a laxity on the lateral side and contraction on the medial side, if you are operating on a conventional method, we know that in such a difficult situation, we hardly able to manage these cases with the 6 mm or 5 mm or 7 mm insert. We always require a higher insert. So on the second post-operative day, patient was allowed to stand with the help of walker. Coming to the robotic part, the system with what I am using is a Velis. We put the 2 pins on the femur and 2 pins on the tibia, and we attach the optical trackers on both the pins. Then comes the registration part. We register the distal femur. We register the axis of the femur. We register the anterior cortex, both medial and lateral condyles, distal part as well as posteromedial and posterolateral part. Then comes the registration of the tibia. We register the proximal tibia, then the axis of the tibia and ankle. And then comes the equivalence graph. With the help of all these registration, that robot or computer creates a 3D model, and we check the equivalence graph, whether how much opening is occurring on medial side and how much opening is occurring on the lateral side. So this system is basically a 4th generation robot which has a compact table mounted system. It is basically a saw-based system, and with the real-time based navigation, it doesn't depend upon the preoperative CT scan. It's a real-time based system. And we can adjust the femoral component differently. We can flex the femoral component, we can actually rotate the component, and we can change the intraoperative planning while after cutting the tibia as well. And this is the sensor tensioner, which is a very beautiful device that has been provided with this system. Once we cut the tibia, we can put this sensor tensioner in between the gap, and we check the flexion and extension gap at a different angle. In a conventional method, we check the flexion and extension gap at 0 degree and 90 degree only, but we cannot check the gap at 30 degrees, 60 degrees, 75 or 110 degree. But with the help of this sensor tensioner, we can check whether the medial or lateral opening is occurring at different angles. So, this system is basically works as a guided missile. If your assistant moves tibia, front, back, medial, lateral, that this saw blade moves and go and cut in the same plane again. So in this video, I'm moving the tibia front and back, and you can see that a robotic arm is moving along with that. So it will cut in the same plane. It will not change its plane with the movement of hands. And it's always under the control of surgeon. Coming to the literature part, image-free robotic assisted system by total knee arthroplasty improves the limb alignment that have been published in the Journal of Arthroplasty. These are my initial few post-op X-rays of AP and lateral. Now looking, all these X-rays looks similar. Now looking the post-operative X-ray is almost all cases are similar, because you are on table knowing that your cuts is perfect on tibial as well as on the femoral sides. Coming to the literature part, again the robotic arm assisted total knee arthroplasty gives better results. It gives improved accuracy and precision. Soft tissue protection is also there, and it also improves the patient satisfaction. With these words, I would like to thank you all for patient listening.
Some questions. Actually, you have two workflows in the Velis system. So, do you do the tibia first and use the sensor tensor always, or you go for the femur first?
Sir, if you, personally I prefer tibia first, because I can put the sensor tensor in between, and during the surgery I can change my plan while placing the femoral component.
So you remove the meniscus and everything?
Medial meniscus always,
yeah,
and lateral meniscus sometimes.
Okay.
So,
Sir, if you are cutting the femur first, then putting the sensor tensor in between, and it's not possible, and we cannot readjust, and we cannot replan intraoperatively.
I think in Velis system that is a great advantage, that you have this sensor tensor where you put this tensor and equal pressures are applied. Whereas in other systems, there is no objective sort of analysis. The force which I will apply in flexion extension will be very difficult, because the force which apply on extension will always be more when you go take the limb to more than 60 degrees of flexion. It's difficult to apply it because the hip rotates. And so this sensor tensor, if you take the tibia first, is of a great use.
Just want to ask you, this sensor tensor which you are applying, can you measure the amount of tension you are giving, or is it just the field which you are getting?
Sir, this sensor tensor is basically automated system. It has some spring system that stretches the soft tissue. So once we cut the femur.
Rajkumar, you want to say something about that?
No, he's correct. Please go ahead.
Yes, sir. So once we cut the tibia and we create a gap between the femur and tibia, we put the sensor tensor in. It has some spring mechanism that stretches the gap While doing a flexion and extension, we can check that gap on medial and lateral side at a different angle.
So
from
his
0 to
question,
130.
his question was whether when we measure the pressure, but that cannot be measured, it will not show, but it will only show the gap and the graph will show you.
The advantage is that it applies the equal pressure
Yeah.
to medial and lateral side.
Yeah.
And we
Because
have-
with the Z retractor, what we do in other systems, that is very difficult to apply on the lateral side because lateral tibial plateau is convex and medial is concave. So it fits well, Z retractor, whereas this fits well. The only issue is that now you showed your case where you said that you took the tibia in 2 degrees of varus. So that you determined before putting the sensor tensor. So that is the catch. When that is an arbitrary cut.
So
Whereas you don't decide it later on.
No, but,
so in a varus, you by default take 1 degree, 2 degree varus on the tibia.
the graph, the planning allows in such a way that you plan it fully,
Right.
both the femur and the tibia, and try to get your balance perfectly done, and then you do the tibial cut, and then again you put the tensioner, and then after that tensioner, if you see some adjustments you can do in the femur. So that
it gives you two
chances.
Yes, yeah.
But again, after doing all those cuts, again you can come back to the tibia and you can even do extra more cuts, you can recut. So that is another big advantage.
Sir, before the cuts, that graph shows the gap between the both sides, medial and lateral. Once we cut the tibia, many times it removes the osteophyte as well. So that creates sometimes 1 or 2 millimeter extra gap. So readjustment is always required, or cross-checking is always required on table. And one more point for sensory tensioner, sir. Sensory tensioner that is available is in two sizes. One is for 2 and 3, and another is for 4 and 5. The bigger one has a more pressure or has a thicker spring, which stretches the soft tissue more. So according to the size of the tibia, you can change your sensor tensioner as well.
So this is for Wallace users. Like you put a flexion of 5 degrees in the femur and you had a 5 degrees of slope. So are there any restriction in the boundaries to how much you can go? For example, in the system which I use, the combined slope and the femur flexion cannot be more than 8 degrees. That's one. Secondly, was this a mechanical alignment you have executed in this patient? Because your tibia was in varus.
Yeah.
So I presume that it was like a mixture of mechanical going on to the functional, or
It was in between the anatomical and
See, in this case, you cannot put this as an pure an alignment or purely a mechanical. In fact, now he has put the tibial tray in 2 degrees of varus. So it is purely on the basis of the balance what he wanted. So he has put the tray in the 2 degrees. So it is.
you accept 3, 4, 5?
See, that is again a big debate. See, that is a big
There is
debate.
no,
If you
this
see.
thing, as far as this very much personal variation is there, like he's saying, my boundaries are set to 5 degrees of combined varus or 3 degrees of valgus in a valgus knee. I don't cross 5 degrees, but I have met surgeons who go to 5 degrees, 6 degrees of varus in tibia also. So I don't
Here,
agree with
at
that.
this stage, I would like to mention one single point. Nobody has got a definitive value for this at this stage. Like he is saying 3 degrees, you might say 2, I might say 4 or 5. In last month in Melbourne, in the Society of Robotic Surgery meeting, we both were there. Some surgeons, they are telling you can put it in 7 degrees. Nothing happens. 8 degrees. Oh my God, that's crazy. Nobody knows. So at this stage, like 2 or 3 degrees seems to be a safer side, and try and see how it works. Then you keep increasing, but whose cost? So you have to be very careful. So now we have to be very clear what alignment we are going to do, whether it is mechanical or non-mechanical. That non-mechanical is, many names are there, kinematic, constitutional, functional, so many things are there. If you are doing mechanical, you do conventional or robotic, no problem. If you are doing non-mechanical, it has to be technology assisted, that's all. What kind of name, how we are going to achieve, it is individually the surgeon's experience and the patient.
The reason I asked you this question is, you gave some varus in the tibia. In a mechanical alignment, your external rotation is given to compensate for the 3 degrees of varus, which you are cutting at 90, correct? So you're giving 3 degrees external rotation in the femur. Now here you have got 5 degree of ER in the femur and 2 varus in the tibia. So your boundaries of external rotation, is there anything to stop you?
In the system,
Because how are you giving 5 degrees of external rotation in the tibia and 2 degrees of varus in the tibia? That means we are purely acting on the bony cuts and not at all taking into the account the soft tissue component.
Now there is a concept of functional alignment is coming. There is lots of literature are there in the journals that suggests the functional alignment where we can accept the, as sir has told, the 5 degree combined varus, not 5 degree varus in femur or tibia. Both the combined varus we can accept up to 4 or 5 degree. So regarding this case, this case was a complex primary varus and not a mechanical varus was 41 degree. So to correct 41 degree mechanical varus by perpendicularly cutting the tibia and femur, after all these cuts you may not be able to achieve perfect balance. So it's better to achieve to do a 2 degree varus femur and tibia and get a functional alignment. So there are
I think we
enough
will have to
literature
move to the
on-
next
Move to the
speaker
next case.
because there are a lot of robotic related talks. So I invite Dr. Anil Arora for robotic assisted valgus knee in CT based fully automated system.